Still, many clinicians haven't heard about the concept of physician orders for life-sustaining treatment, or POLST. At least that's what we call it in New Jersey. Other states might call it MOLST, some states call it POST or MOST, but they all basically mean the same thing. What we're trying to do is get patients to play an active role in the decision-making of their future care. You know, Medicare spends about $50 billion each year on the last 2 months of life. We know that it's a costly time, and unfortunately, many patients suffer at the end of life. Intensive care unit, unnecessary treatments, mechanical ventilation, feeding tubes, all things that people might not want if given the option. But unfortunately, we don't let our wishes be known in advance. So these programs have arisen in most states, and actually in New Jersey it's a law. This is an actionable order called a POLST, and it's written on a form called a POLST form. This is a funny colored green piece of paper that patients are supposed to leave hanging on their refrigerator with just 4 or 5 sections about their medical directives. I do or don't want to be resuscitated in the case my heart were to stop or in case I stop breathing. I do or don't want artificial feeding or nutrition, the kind of care I want. I do or do not want to be transported to a hospital, these kind of things. And the studies have shown that simply by making your wishes known, even as simple as a 4 or 5 item form, really changes the outcome in the world of healthcare. It obeys patients' wishes, and it's better for everyone involved. So one of the most common questions is, what is the difference between a POLST form and an advance directive? And there are some subtle differences and some gray zones. One of the differences, an advance directive is something we could do when we're young and healthy. We go to an attorney, we have a will drawn up, maybe we get some trusts or get our estate in order, and we come up with an advance directive. This can be a 15 or 20-page legal document full of legalese and language that many clinicians, nurses, healthcare providers might not understand or have the time to read in the case of an emergency. Now that document stays with you forever until you change it, and it states your wishes. But what we found on the front lines of medicine is that if someone comes into an emergency room, they don't have their advance directives with them. And even if they do, how is a clinician in a matter of minutes going to read a 15-page legal document and decide what to do and what not to do? So unlike an advance directive, a POLST is really meant to accompany the advance directive. Hopefully they both say complementary messages, but the POLST form, you look at it and in a matter of seconds you could tell whether the patient wants resuscitative measures, feeding, artificial ventilation, these kind of things, and they really are meant to go hand in hand. So many states have adopted policies like POLST and MOLST and MOST. It started back in the early 1990s in Oregon, where they saw the system as illogical, that there's an order called a DNR, do not resuscitate, and that's an actionable order. When a patient gets admitted to a hospital, a clinician needs to fill out and sign a DNR form. When they get transferred to a skilled rehab facility, someone else needs to fill out and sign a DNR form. When they get back to their nursing home, someone else needs to fill out and sign a DNR form. If they come back in the hospital, the same process repeats itself. An illogical process of having to figure out, sometimes from perhaps not a mentally competent patient, what are their wishes? Well, the POLST or the MOLST system seemed to change that because, as I mentioned before, this is a medical order. But the difference is it's enduring. It goes with the patient from place to place to place, including their home, and acts as an order for clinicians and EMS workers and firemen of what to do in case there's an emergency. So for example, in New Jersey, we have these green forms, and the instructions to patients are to hang them on your refrigerator. And it sounds kind of funny, but EMS is instructed to look on the refrigerator when they go to a house to see if there's one of these forms that clarify what are the patient's wishes for further treatment. So I'll tell you what I've been recommending to my colleagues, which is what I've been doing in my own office. Although I said before advanced directives are something we do in advance, and POLST is something reserved for later in life. I mean, if you read the formal guidelines for POLST, it says, use this form if you wouldn't be surprised if the patient had a life expectancy of less than 1 year. But I've taken a little bit different approach. I leave a stack of these green forms in my office, and if you're 50, 60, 70, 80, 90 years old, I open the conversation. I say, here, I want you to take this home. You don't have to bring it back to me. You don't have to sign it, but I want to give you an idea. We create our own destiny. Most people don't have the opportunity to make their own medical decisions because it's too late by the time arises. So I want you to read this form. All we want as clinicians is to obey your wishes. We want the best possible end of life for you. I say, look, we haven't figured out a cure to life. Everybody dies, right? But when the time comes, we want you to die the way that you want. So do you want to be in a hospital? Do you want to be home? Would you like to go on machines at the end of life? Or would you like allow natural deaths? AND is actually an order, allow natural death. And it forces patients to start to think about what they want for their future if the time were to arise. And they sign this form. It becomes part of their orders. It's part of the medical record, and they keep a copy at home. But it's not permanent. They could rescind it at any time. They could change it at any time. They could void it, make a new check mark, we give them a new form. So it's not like they need to make the definite decision now, but it gets them to start to think about it. So I think really as time moves forward and as we realize that many patients are suffering at the end of life when they don't have to, it would be nice to get patients involved in the decision-making of their own care now, because maybe in the future they might not be able to participate.